Welcome to Urgent Care Consults Incorporated. My name is Michael Boyle. I'm an emergency physician by training and recently obtained my MBA through the University of Phoenix. We're going to talk about the expanding use of urgent care centers and describe the differences between a cash clinic, a retail clinic, a hospital-affiliated facility. We'll talk about optimizing your location, ensuring that you have the best site with the best demographics. And then we can discuss expansion of different business modalities, and this could include occupational medicine also. This is an incredibly good time for expansion into urgent care, whether you're doing it as an entrepreneur or whether you are a hospital that's considering expansion into the community. There have been 300 to 400 new urgent care centers per year in the last 5 years. 23 freestanding EDs have opened up in Texas, specifically in Houston and Dallas. Most of these are private. There's some licensing questions and issues that are going on now. Why is all this happening? Because there's ED overcrowding, there's lack of primary care provider access, and there's going to be new volume from healthcare reform. There are 3 big players in the market that are private: Concentra, AFC Doctors Express, and MedExpress. These have been paired with private equity that's improved their financial positions. And in Delaware, you'll see on the right, on your right hand of the screen, that they have developed criteria for freestanding emergency departments, and I think you'll see some legislation with urgent care. Healthcare reform, that was the big deal in the last 5 years. There are currently about 130 million emergency department visits. 45 million people are projected to be newly insured. I think the real number is closer to 40 million. And unfortunately, at the same time, there are 20,000 PCP or primary care physicians lacking to provide the care for this population. It's important for you as a professional to know the healthcare reform laws, know the opportunities that you have, and know personally what it's going to cost you and your employees. Let's talk about some basic information on urgent care. Why is it lower cost? Well, first of all, compared to an emergency room, there's no night staffing because at this time during the night, there's typically lower volumes, and you can't really pay for the staffing in an emergency room, but you have to have it there. Second, there's very low acuity with rapid turnover. Our staffing suggestions typically 9A to 9P. You can shift it either way, or an hour or 2. This minimizes overhead. You only have 1 shift, but you need to watch overtime. It's interesting that at 8:30, the entire world decides to show up right before you're closing at 9, which causes people to work over. What you may want to consider is actually closing at 8:30 so that your staff can get out at a reasonable time. Staffing, what we suggest is obviously a clerk, an LVN, maybe an RN, a physician, and or a mid-level provider. We'll talk more about the staffing level. To define, there are several different concepts in urgent care, and most people don't define these areas that I consider as urgent care facilities. There's the cash clinic, and this is typically a smaller site, 3 to 4 rooms, and most often indigent care or Medicaid. The best location for this we'll talk a little bit later, but it should be close to access for the bus line and close to a very busy emergency department so that the ED can screen people and refer them out. Retail clinics, the Rite Aids, the Walgreens, these are 1 to 2 rooms staffed by a nurse practitioner. Again, we'll talk about this a little bit later. Then you have the majority of the urgent care facilities that most people are familiar with, privately owned. Often volumes are between 20 and 40 a day. They have wave testing and also have DR, most often and now DR radiology capability. And lastly, there's the high-level urgent care center, often owned by a healthcare system, and this is the urgent care on steroids. with an adjacent imaging center, occupational medicine, and several other business ventures in one building. So what's the competition? Well, the biggest competition that I think we're seeing are the retail clinics. They have price transparency. Prices range from $50 to $70 for sore throat, sinusitis, URIs, immunizations. They're fast, 15 minutes for registration, and completion of care is usually in 30 minutes. Now, as they get busier, they will slow down. They have solid technology, internet registration, kiosk registration, scanning of information. This is all done by the nurse practitioner. As I just said, they are staffed by nurse practitioners, and the majority of what they see are 6 primary diagnoses: sore throats, upper respiratory tract infections, physicals, immunizations, and urinary tract infections. Yeah, their break-even point is pretty low, 15 patients a day. What's the big change with the Affordable Care Act? That's accountable care. And accountable care organizations, or physician hospital organizations, I'm not going to go into detail about, but simply to identify that these are networks of primary care specialists and hospitals, and they are responsible for managing a population, and they share savings. Now, again, I'm not so sure that there will be any savings in these organizations, but if there are, those profits, quote, are shared back with the facilities. Now, what does urgent care have to offer accountable care organizations and PHOs? Well, they certainly can offer ED overflow, especially for the lower acuity. They can offer physician office overflow, commonly occurs in large clinic practices. Example of that would be the Kaiser offices in Northern Virginia and Fairfax. Follow-up care from the ED. Lots of patients have to return to the ED for cellulitis rechecks, for suture removals, for occupational medicine, or maybe a recheck of the blood pressure just because they don't have access otherwise. This would be a great population for you. Hospitals are doing everything they can to reduce readmissions, and you could serve as a post-discharge clinic. This could be a nurse visit. The patient, after they're discharged from 5 days of hospital stay for congestive heart failure, a heart attack, or something similar, has their medications checked, has their weight checked. The nurse reviews their post-discharge instruction, and all of this is education to reduce the readmission. Another possibility, though, it's going down because of the new 10A inhibitor oral medications, but Coumadin clinics or PT evaluation clinics are some possibility, especially when you're affiliated with the hospital. And last but not least, I've had my share of experiences with disaster. I was in Houston, Texas for about 8 years, at which time we had Tropical Storm Allison, Rita, and Katrina. We closed many EDs. And if you have an urgent care center and you built it correctly, they can be easily converted into an emergency department if the need arises. I would imagine that Joplin, Missouri would have loved to had that ability after they had the F5 tornado strike their facility and close the entire hospital. Anyway, food for thought for those that are hospital-based people. So what do you do? If you are a hospital, do you lose the lower acuity market and just try to ensure that patients that need admissions or procedures get referred to you? Again, not that much from an economic loss, but maybe significant depending on your emergency department and its volume, and if you have affiliated urgent care. Do you purchase or affiliate with a local urgent care clinic? Could you provide physician oversight for the Walgreens and the Rite Aid's minute clinics of the world? Or do you build a better mousetrap? And my thoughts are both from the entrepreneurial side and from the hospital side. Mousetrap is the option. What do urgent care centers do? Well, certainly in these days of competition, they fortify the defenses. If you place 4 or 5 urgent care centers around your hospital within 5 to 20 miles, you protect yourself from someone else invading your territory. In addition to that, you can make the first shot against the competition by placing a footprint in in a previously unchartered area. You could medically screen patients in the emergency department and refer them out to a cash clinic that you've sponsored. Probably the biggest thing is you need to beat the competition. The Med Express and Doctors RX are coming to town, Concentra also. And again, these are moderate to high volume, and they will remove acuity and volume from low acuity and volume from your emergency department and your current urgent care centers if you're not managing correctly. The other thing that we've experienced is when a hospital, for whatever reason, closes, it is a great idea to retrofit the emergency department as a high-level urgent care center along with an adjacent. So what size do you need? Anywhere from 2,500 to 4,000 square feet, depending on the purpose of your clinic, whether it's cash or whether it's a high-level urgent care center. I think 5 to 7 rooms with certainly at least one procedure room. You definitely need 3 restrooms, one in the front, one in the back for staff, and one for drug testing if you're planning on doing occupational medicine. Do you rent or do you purchase? There's a lot of money that you put down when you purchase. You need to look at your own situation. But I will tell you, there's a lot of vacant real estate that is available just simply through the financial disaster of Blockbuster. These facilities are awesome. They have the right number of square footage, and they're in very good demographic areas. Blockbuster did the research. Don't bother doing the research. Find a Blockbuster that's vacant and retrofit it as an urgent care center. Location, location, location. Cash clinics need to be close to the hospital, close to targeted zip codes, bus and subway lines, and you can almost survive on $50 a patient depending on your cost structure or your the costs of equipment and things. I wouldn't necessarily have X-ray available. You can consider it. It certainly should be a mid-level model. 20 patients a day will make break even. You need to evaluate the cost savings versus the revenue generated. Even if you lose money in the cash clinic, you will save money by freeing space up in your emergency department, and you may actually increase your volume of paying patients. You just need to evaluate your ED flow. That's the most critical thing. Where do you put an affiliated urgent care center? Traffic volume is the primary thing. Over 25,000 cars passing the facing street. This can be determined by your Department of Transportation or your local municipality. You certainly can get information on population by the census in the municipality, and the density of greater than 25,000 people in a 3-mile perimeter is what can support a good urgent care center. Try to look at an average income of greater than 50,000. Now, the question is, some people say, oh my gosh, there are lots of people going to medical office buildings. Why don't we just make an urgent care center? In my opinion, strip malls or freestanding sites, again, especially Blockbusters, will be a much better. What about an adjacent imaging center? If you're a hospital, I certainly suggest this. A person that comes to the imaging center, the soccer mom that is there to get her bone density done or her mammogram, will realize that little Johnny has a place to go for his urgent needs, and most of little Johnny's needs are a sore throat, laceration repair, and even if he falls and hits his head, then you have CT capability. So the co-marketing of an adjacent imaging center, I think, is incredibly valuable. Staffing. So how do you staff it? Again, as we said before, 12-hour maximum avoids 2 shifts, reduces overhead costs, unless your volume is really high in the 70-plus range. A cash clinic, simple, basic staffing, registration clerk, and LVN, probably don't need an RN, a nurse practitioner, and a physician medical director off-site that can provide chart review based on your state requirements. Urgent care center, depending on your volume and what your expectations are, you need a registration clerk, medical technologist, not a lab tech. but or an LVN to apply splints, do vital signs, set up suture sets. Many of the private urgent care facilities do the LVN model as opposed to RN. When you get busier, you're going to need somebody to administer medications. And again, it depends on your state requirements as far as care and staffing levels. Do you put in a lab? I would strongly discourage this because I think the better option is just a regular draw station with the lab person that can run wave testing. Radiology tech, you're certainly going to need one, and you can cross-train this person for other registration. Probably the most overlooked and underappreciated group of people in the entire organization. You have got to pay these people well to keep them verifying insurance, collecting copays, ensuring that people have urgent care benefits. You can deny care since you are not an emergency department. The blues, if you have a contracted physician group independent from the hospital, do not pay a facility fee. So that's an issue. You need to spend the right dollars to get the right people, and registration people don't make a lot of money, but they can cost you a lot of money. Make sure they're collecting all their copays. Consider collecting a portion of the visit, especially with high deductible plans. Well, what should you see? Self-pay, maybe. Depends on whether you're a cash clinic or not. If the patients are willing to pay 50 to 60 bucks for their care, that's certainly an option. Medicaid, maybe. Again, depends on your situation, your state reimbursement, and your cost. Essentially, you just need to know your cost of care. Medicare, I would certainly say yes. Now, obviously, with all the Medicare changes, you could have some issues, but you're not going to have a whole lot more than 10% of your population as Medicare. The most important thing for both Medicare and Medicaid is to ensure your providers are already enrolled before you start seeing those patients. Because a lot of times if you try to enroll after seeing them, it will take you over 6 months and you may lose some revenue from lack of enrollment, and they will not retroactively reimburse if the billing is delayed too far. So ancillary services, we talked a little bit about this. I would suggest a draw station, especially if you have a main hospital lab that has significant unmet capacity, the hub and spoke idea. Urine dip reader and wave testing for strep spraying, for influenza, for pregnancy testing, and similar things. I strongly recommend radiology, at least the DR, maybe not CT, but again, if it's hospital affiliated, I think you should have a full complement so that you can co-market. Clinical care, not so surprising here. Sore throat, upper respiratory tract infection, bronchitis, 60%. Minor injuries, ankle, knee, wrist, back strains, and fractures, 20%. You will see some chest pains. You will see some neurologic complaints. And you simply have to have a process and plan to get those people expedited. Risk management, remember that you have to have a plan, and surprises happen. I can tell you that in our experience, and all those upper respiratory tract infections, coughs, and shortness of breath, especially in flu season, lives 1 or 2 PEs that frequently have a bad outcome if they're not diagnosed correctly. And diarrhea, vomiting, gastro season, there lives a couple of appendicitis patients. You have to have a high index of suspicion. The other important thing is vital signs are abnormal. They're usually abnormal for a reason. A lot of times it's staff related and they weren't taken correctly. But if they're abnormal and you repeat them and they're still abnormal, there's a reason for it. Resting tachycardia is a harbinger of bad things like a PE. So keep that in mind. Challenges, again, have a plan for any patient that comes in with acute myocardial infarction, CVAs. You will get some patients with anaphylaxis, so have your epinephrine available. We've had babies delivered in the parking lot. Again, policies and procedures. Do you bring those patients in? What do? You just need to prepare. I'm an advocate of a fully stocked code cart, whether you're a privately oriented urgent care center or whether you're hospital affiliated. You certainly need it if you're hospital affiliated because you're going to get higher acuity patients. You need to have a policy and procedure manual to define the expectations of any of these cases and all of your other procedures. So hospital affiliated sites, we've talked about the clinical care. There's typically a higher level of staffing and equipment. There's a higher volume because of the co-branding, but the competition is coming. Thoughts? You know, if I'm talking to a hospital administrator, do you build a new one? Do you add on beds? I would not do either one. I'd go about 5 to 10 miles away from your facility, build an urgent care center so you offload the low acuity and you improve or increase your inpatient capacity by building beds there. The urgent care capacity of lower acuity patients have a better experience, have higher patient satisfaction, and a more rapid turnaround time in urgent care than they do in the ED. It decongests your ED for those sicker patients that will need those inpatient beds that you're going to increase. Business expansion, you can consider doing sports physicals. Could be a lost leader in your program where you charge $20 to $30. You get them in the door. It's low cost to you other than provider time. But again, you get the marketing and you get the downstream business. DOT physicals, a little bit greater risk. Now you have to be certified. Immunization clinics work well. I certainly think we can compete with the Rite Aids and the Walgreens. Immigration physicals are certainly an idea, incredibly good cash paying business. However, you have to be certified and there are limitations by region of country. Occupational medicine, my plea is if you're going to do it, you do it right. You need to have a practice manager or someone that markets the business, sets up the profiles. The facility, if this is a hospital-owned facility and an independently contracted the provider, the facility makes the money on the physical therapy, radiology, CT, MRI, and whatever potential surgeries they get. Paperwork is annoying and frustrating. You have to have somebody for that. You also have to have care pathways in the state of New York. If you don't follow your pathway and order an MRI sooner than you should, you won't get paid for it. You certainly will get spillover business from occupational medicine from the family of the employed person. I've truly enjoyed giving you this presentation, and please feel free to contact me at Urgent Care Consults Incorporated. We can help you with your revenue. We can help you with your setup. We can help you with your management and any other questions. So thank you very much and have a great day.